Is it my turn? Okay.
All right. Well, so thank you all for joining this evening. It's my pleasure to introduce Dr. Lindsay Strader. Dr. Strader is a colorectal surgeon in Wichita, Kansas. And she hails to us. Lindsay, I didn't ask you where you're from originally. I know you did your undergrad at Manhattan, but I wasn't sure where you were from originally.
I'm from Wichita.
From Wichita. Okay, so Wichita native who has returned back home after doing medical school, and then your general surgery residency there at KU School of Medicine, Wichita. And then your colorectal fellowship was at Southern Illinois University, correct? And then has gone back to Wichita and has just been extremely involved in multiple committees in both the colorectal world as well as our Kansas chapter of the American College of Surgeons. And then a lot of leadership committees too within the American College of Surgeons. So she was gracious enough to agree to present to us this evening on colorectal surgery and some of the Commission on Cancer standards. And most impressively, after agreeing to present, for those who watch the call later, it was quickly followed by, oh, and I'm about to have a baby. Yeah, I should be back by that time from maternity leave. So impressive that she was even willing to entertain the request. So I'm thrilled to hear you speak tonight and can't wait to hear all your great info.
Thank you. Okay, let me try and figure this out. Share my screen. Okay, so you can see my screen. I'm assuming.
Yes.
Okay. Okay. So I was very, grateful to be asked to speak tonight. And you had asked me, Dr. McAllister, to talk about something in terms of new advances, and the world of colon is pretty much straightforward, but we are seeing a lot of changes in the rectal cancer world. And so I decided to talk about that tonight, and then we'll transition back to colon at the end when we start to talk about the standards. So I wanted to talk about the evolution of the management of locally advanced rectal cancer today. I have no financial disclosures. I hope this talk is as straightforward as this dog and his light, but again, I did just come off of maternity leave, so hopefully we're all on the same page here. But I wanted to talk about the evolution of locally advanced rectal cancer. So tonight, I'm really just talking about rectal cancer that has eroded through the wall or essentially into the lymph nodes around that area, something that would require advanced treatment. And we're going to discuss in the realm of that, the inclusion of non-operative management and total neoadjuvant treatment in locally advanced rectal cancer. Then we'll kind of transition, we'll take that step back and transition to the key elements of colon cancer surgery, and we'll discuss the value of synoptic operative reporting and operative standards in colon cancer. There's a lot of different people who are joining us tonight or joining us on the recording, and that includes, I saw on the list, physicians and nurses and cancer registrars, and it just is a lot of people. And so I hope this talk can kind of find some aspect for everybody in it. So my experience in colorectal surgery, I am fellowship trained and board certified as a colorectal surgeon, like Dr. McAllister said. I just started my 8th year in practice now. I am currently the physician liaison for the Ascension via Christi Commission on Cancer Committee, and we did undergo our reaccreditation this year and were approved. And then I perform surgeries, and I'm on working with several hospital systems in order to undergo approval of the National Accreditation Program for Rectal Cancer. And that is a whole process in and of itself, but I do quite a bit of work in colon and rectal cancer. So in terms of the history of rectal cancer, over 100 years ago, we really were leaning mostly on radiation to treat it, with surgery being sort of a salvage treatment. And that's mostly because surgery was so dangerous at the time in terms of anesthetic and survival with limited antibiotics. And then as surgery became safer and we realized the limits of radiation, we started to use surgery as the mainstay of treatment, and then radiation transitioned to adjuvant treatment. Surgery really remained the standard until the 1980s. And that's when we started to look back at research and realize that we weren't doing such a great job of it. Our 5-year local recurrence rates were in the 30 percentile. And that was unacceptably high because those patients are at high risk. not just in terms of quality of life, but also the length of their life. So this led to the recommendation of adding radiation after rectal cancer surgery. And those recommendations came out in the 1990s. And then at the same time, this new research by Dr. Bill Heald, he revealed lower rates of rectal cancer recurrence if we used sharp dissection in the planes instead of what was traditionally used, which was blunt dissection. So to kind of break down rectal cancer anatomy, you have the rectum, and it's then surrounded on almost all sides except for the top with its mesorectum, or the lymph nodes and blood vessels that drain that area. If you can kind of think about it simply as a hot dog and then the hot dog bun surrounding it. And so we used to just take our hand and kind of sweep down there and create those planes. But as you can tell, you might get between the hot dog and the hot dog bun, or you might get around it. And now we use very sharp dissection, meticulous dissection, and that gets us completely around the hot dog bun, which, you know, can take that out in a complete intact specimen. And that really, really led to better rates of lower rates of local recurrence. So a lot of the research regarding treatment before Dr. Heald's research came out is a little hard to interpret because it didn't have very good surgical techniques. We call this TME, or total mesorectal excision, which is where we take out the entire specimen, including the lymph nodes, all in one plane. And then really the first trial to use those TME planes or those principles of Dr. Heald was the Swedish rectal cancer trial in 1997. And it showed improved local control with radiation after surgery. Despite improving our local recurrence with post-op radiation, we still understood that this treatment had limitations. And so it has very high toxicity, very poor patient tolerance or completion rate when their new anastomosis gets radiated, and very poor quality of life. These patients have this new connection that's then radiated, and it becomes very stiff and non-compliant. It doesn't function like a normal piece of bowel. And so these patients are plagued by what we call low anterior rectal syndrome symptoms, which are urgency and frequency and liquid stools and incontinence and, you know, just really, really miserable quality of life. The German rectal cancer study came out in 2004, and that's when we really compared radiation given pre versus post-operatively. And they found that local recurrence was almost half if they gave radiation preoperatively, and all of the toxicities were less as well. And so that really led to us starting to give radiation and then proceed with surgery. And then we found some further improvements with post-op chemotherapy as well. So you can kind of see the evolution up until maybe 10 years ago was surgery, then surgery and added radiation afterwards, then realizing that chemo and radiation would be better before surgery, and then following that with chemo afterwards. So that's really where we were for a long time: chemo, radiation, surgery, and then chemotherapy. But you know, understandably, traditional chemo after surgery can be limited by post-surgical complications. And this can be anything from a surgical site infection to, you know, a high ostomy output, or someone who had their anus removed and has a wound down there. That wound is very difficult to heal. And so all of those can slow down the process getting from surgery to chemo. In addition, a lot of the rectal cancers that we do end up having a temporary ostomy, and I can't reverse that until they're off of chemo. So if they get chemotherapy after surgery, they might have that stoma for 4 to 6 months, when in reality, I could take it down in 6 weeks if they weren't having chemo. So we started doing what's called total neoadjuvant treatment or therapy, which is TNT for short. And this means we give all of their treatment up front and then proceed with surgery. So that really allows them to complete their entire course of chemotherapy and chemoradiation with less treatment interruptions. So more people are completing it. And it's really now the preferred treatment per NCCN guidelines. It's supported by a couple very recent trials. So the Rapido trial is what most people talk about most commonly. It's almost 1,000 patients. They had T4 or node positive rectal cancer. Their arms weren't exactly matched, but you can see how they could interpret data from this. So arm 1 was long course radiation. And what that means is 5.5 weeks of radiation followed by surgery or TME surgery, and then chemo. And then arm 2 was short course radiation. Short course is higher doses over just 5 courses, 5 days. And then that was followed by chemo and then surgery or through it with the TME planes. And so that arm 2 is really total neoadjuvant treatment or TNT. And they found that the disease-related treatment failure was lower in the TNT arm, and the pathologic complete response was higher, markedly higher, it was 28%. And pathologic complete response means that when we go to surgery and remove this piece of bowel, there's no longer any cancer in it. And then that data was supported by the Prodigy 23 trial, which is 400 patients. They all had T3 or T4 disease. And these two arms were a little bit better matched. So arm 1 was long course radiation, surgery, and then chemo. And arm 2 was chemo, long course radiation, surgery, and then additional chemo if was optional. So arm 2, again, was the TNT treatment. And their data showed, better 3-year disease-free survival up to 76% in the TNT arm, the total neoadjuvant arm. Metastasis-free survival was also better. And again, the pathologic complete response was 28%. So at least a quarter of these patients did not have cancer when we went back for surgery. And so, of course, that kind of brings up the question, if we're doing such a good job of treating these patients with chemo and chemoradiation, do they need surgery at that point? And so this research and what we call a watchful waiting, which is where they've had a complete response and we're watching them. This started many, many years ago by Dr. Habergama. She's down in Brazil, and it really was kind of presented as experimental. We would talk about it here in the United States, but we wouldn't really recommend it. But her data has been, developing for years and years. And now this is seen as more feasible with TNT. And that's because a patient who with locally advanced rectal cancer treated with TNT has essentially a 25% chance of having a pathologic complete response. So what we do to evaluate whether they're a candidate for watchful waiting is we start their post-treatment evaluation. And this usually is about 4 to 6 weeks after treatment. If they've just had their radiation, they need at least this amount of time to where they'll even tolerate a rectal exam. And a complete clinical response is our way of saying they've met all the criteria to undergo a watchful waiting protocol. So it consists of a physical exam with a digital rectal exam, usually endoscopic exam as well. We usually add that in, and then an MRI with rectal cancer protocol, which is very important to do it with rectal cancer protocol. These MRIs are difficult to read, especially after a cancer is already gone. And usually the same facility that performed the initial cancer study is the best one to be able to read that second one. The actual protocol for watchful waiting really does vary by institution. I don't think we have it completely delineated yet, but generally it consists of intensive surveillance of a rectal exam, endoscopic exam, and MRI on repeated intervals, anywhere from 2 to 4 months is generally what's seen. And so the criteria for declaring them as a complete clinical response would be seeing on the rectal exam or the endoscopic exam a flat white scar without any nodules or ulcers, and their MRI shows evidence of cancer resolution, and usually that shows evidence of fibrosis or scarring as well. The difficult part here is that 75% of people who have a complete clinical response, or what we think their cancer's gone, when we go back for surgery, it's actually not. And 75% of those who still have a cancer at the time of surgery didn't meet criteria for complete clinical response. And so that gets very confusing about, are we doing the right thing? And I think this sort of chapter is still working its way through, but it is certainly an option, especially for people who are going to lose their anus and have to have a permanent colostomy. This is definitely an option that many would choose. So on the left side of the screen, you can see that is an incomplete response. You see the yellow arrows are pointing towards an ulcer that's covered by fibrosis. And so that's not, there could still be cancer in any type of ulcer. And then at the top of that screen as well, under the word age, you can see a little bit of mass still leftover tissue there that doesn't look normal. So that is not a complete response. Whereas the right side of the screen, right underneath that piece of stool, there's a flat white scar. There's some telangiectasias or red blood vessels, and those are normal after radiation, but that flat white scar is really what we're looking for to say that this cancer is gone. And of course, those images would have to be supported by MRI evidence that the cancer was resolved as well. So the advantages of watchful waiting, certainly, anytime we avoid surgery, you're going to decrease your surgical complications. And specific for rectal cancer surgery, with these patients, we have to talk about sexual and bladder dysfunction. So that means urinary incontinence, where they leak urine all the time, urinary retention, where they have to use a catheter to have urine to void, sexual dysfunction like erectile dysfunction and retrograde ejaculation, fecal incontinence, they might leak stool all the time, and low anterior rectal syndrome, which we talked about earlier, is the urgency, frequency, liquid stools, fecal incontinence, that kind of stuff. So anytime we don't take out the rectum, that the risks of those are less. And some of those are affected by radiation, but not in the amount of impact it is to have radiation and then surgery. And then you avoid typical post-op, complications, surgical site infections, anastomotic leaks, hernias, DVTs, and any type of ostomy complications. If you're not creating an ostomy, you don't have to be readmitted for dehydration. Of course, the biggest advantage for anyone with watchful waiting would be the avoidance of a permanent stoma. This is someone who has a cancer that's too close to the anal muscles, and we would have to remove that anus and give them a permanent colostomy. And this is by far the majority of my patients on watchful waiting protocol who choose to go through with that are patients that would otherwise have a permanent stoma. And then disease-free survival is 93% and overall survival is 91%, and that's supported by the Dutch data. Disadvantages, typically we say if recurrence develops, salvage surgery usually can be used, and that can make you a little uncomfortable. Local recurrence in the pelvis, if it is not found early, can be devastating, can be life-threatening, and really is kind of a miserable surgery. So salvage surgery typically can be used. There is a distant metastasis rate of 8%, which is Memorial Sloan Kettering data. That's very close to what it is anyway with typical rectal cancer surgery. So, you might be watching the rectum for a local recurrence, and really 3 months down the road, you might find cancer in the liver. And that's, you can see that with anything. And then the cost is definitely a downside of the watchful waiting protocol. If you're getting MRIs every 3 months, eventually that's going to add up to be higher than the amount that it costs to have surgery. So, as you can tell, we started off we left off with chemo radiation surgery and then chemo, and now we're going to chemo followed by chemo radiation followed by surgery, or maybe not even having surgery. So we've gone complete full circle from surgery being really our mainstay of treatment to it maybe not even being included in 25% of patients. So it really is kind of an interesting time right now in terms of treating rectal cancer and how good we've gotten at doing that. And by we, I mean the radiation oncologists and the medical oncologists. So grateful for them. And for now, they still need me for most of the time. So, okay, so we'll transition here to kind of the colon cancer part of the talk. And so in terms of colon cancer surgery, in 2020, the Commission on Cancer released these operative standards for quality cancer care. And it wasn't just for colon, it was for others as well. But the mainstays of colon cancer surgery are really these two principles. And the first one is that proximal vascular ligation with regional lymphadenectomy. So what that means is when we go in for a colon cancer, we take out the piece of bowel. Usually we talk about 5 centimeters proximal and distal, including the lymph nodes in that area. And we want to take the lymph nodes at their very highest area that we can, which is a proximal vessel ligation, so that when we take the vessels that high, we get all of the lymph nodes that are draining from that cancer and hope to get all of that disease out as well. And then principle 2 is, any involved adjacent organs, if this cancer is eroding into something else like the spleen or the omentum, that should be removed all in one specimen, not separated and then removed. So these are a little blurry as they came up, I can see, but on the left side of the screen, there's the blue and yellow colon. So that's a colon cancer on the right side of the colon. And so we would end up taking that entire right side, including the appendix and the first part of that small bowel there. But really the important part is taking those blood vessels as they come off very high off the SMA, so that the ileocolic artery, the right branch, or I'm sorry, the right colic artery and the right branch of the middle colic artery. So taking those is a good, quality cancer resection. And then on the right side of the screen in the purple and pink colon, there's the cancer in the left side of that colon, and taking that, inferior mesenteric artery is really going to be those feeding blood vessels there. And then this is a picture just of transverse colon here, and you can see all the blue arrows that are pointing towards that's cancer that's basically metastasized to the omentum. And so you would want to take out all of that omentum along with that piece of colon right there, just in one section. So the ACS launched these 4 operative standards in 2020. Their goal was for them to be implemented by 2023 by all cancer accredited sites. The first 4 sites that they released 2 breast for sentinel lymph node dissection, axillary dissection, primary melanoma, and then colon resection. And their plans are to expand that to further cancer sites. The goal is a 70% compliance with this by 2023 and 80% compliance by 2024 and beyond. And really the key element of this standard reporting that they're looking for is these synoptic operative reports. Now, when I first started started hearing about this in our COC meetings, I really had no idea what a synoptic operative report was, but I just nodded along because everyone else seemed to know what it was. But I think over time, I realized that most people maybe don't know. And so we're just going to talk about that real quick. So a synoptic operative report is really a blank document. It's got specific data elements that need to be addressed based on the type of cancer you're removing. And it's presented in a question and answer format with predetermined answers that you can choose from. So on the left side of that chart is a narrative format. And that's what we're used to dictating. We're used to, if anyone's ever been a transcriptionist, you're used to the surgeons just, narrating on and on and on with all of this detail that many of which is not very important. But that can be very difficult, especially for the cancer register people to, get data out of that, to abstract data from that in order to determine if we're giving quality cancer care, because you have to go through every line and figure out what exactly the surgeon was trying to say and go from there. And so on the right side of that chart, there's a synoptic operative report. And you can see that, the first question is operation performed for curative intent, yes or no? And the next one is, was the resection performed within these boundaries, yes or no? And so it's very straightforward, easy to get data from, easy for the surgeon to know what the key elements are and going from there. It is very important to still do a narrative description of the case. I mean, the synoptic operative report should not replace that. It really should just give the key elements that are necessary for cancer care. So let's see, we'll go to this next slide here. So this is the synoptic operative report for colon cancer. So the first one is probably the one that I do the least in my narrative report. It is not often that I say this operation was performed for curative intent, because in the mind of a surgeon, most of our operations, I would say, are performed for curative intent. So I think this one is really important to address. Because there are times when we're not trying to cure. If someone is a palliative case, if they, just have an obstructing cancer, but they've got cancer throughout their liver or elsewhere, we might just be taking care of that problem. So the first one, you would just say operation performed with curative intent, yes or no, tumor location, and you would list off where the location was, and then the extent of the colon and vascular resection. So an example of this is, if my tumor location is in the cecum, then my extent of colon and vascular resection would be right hemicolectomy, ileocolic and right colic vessels were taken, proximal ligation. So that would be it for your synoptic operative report. And then you would go on to do your narrative. And if you're in my household and you have a 2-year-old at home, his most favorite question in the world is, but why? And you can see he's got just the cutest little crying face there. And that really is, reminds me of surgeons. We always say, but why? Why do we have to do this? And we're sort of like toddlers running around with knives. So I think it is very important to talk about the purpose of this. So, number one, the purpose, increasing accuracy of that data reporting. As I explained, when the cancer registry people are going through these narrative reports and trying to get, elucidate the data from there, it's very difficult to figure out what that specific surgeon is trying to say and get that data. It also increases the efficiency in data collection. If you don't have to read through every operative report and find the specific data that you want to abstract. So it increases efficiency in abstraction and compliance. We can tell whether we're compliant in a much quicker way. We can tell, were we compliant last month versus were we compliant 2 years ago? It does reduce variability in care if we're all on the same page and all kind of following the same guidelines, and it improves the quality of cancer care. And that's why we're all here in the first place. So how to get surgeons on board with synoptic operative reports? I think the key elements are make it easy to access and efficient to perform. So I gave some options here tonight that we've tried all of these, and just thought maybe I would mention some of them to see if they're helpful at all. But option number one would be just a pocket guide, basically a laminated piece of paper that has the requirements on it as needed for this. The advantages are that it's always available in your white coat and there's minimal to no technology intelligence required. The disadvantages are, of course, you have to have the same white coat on you, and it's easy to lose, which I know because I've lost it many times. And the people at my hospital continue to find it for me. So this is an example of what we're currently undergoing with our rectal cancer accreditation. So you can see that there's 19 separate question and answers that I have to go through for rectal cancer. And so there's no way I could remember all of this, but certainly, being able to read off each one of these is very helpful. And this is what I initially used to dictate, but I ended up continuing to lose it over and over again. So second option, which is what I ultimately do now, is I took a picture of that and I keep it in my folder in my iPhone entitled albums. I have a medical folder where I have medical pictures, and this is exactly what I put in that one. So the advantages are that this is always accessible. I don't know a single surgeon who doesn't have their phone on them all the time. Minimal technology intelligence. I think most of us can figure out how to take a picture and probably how to put it in an album. And again, this is the method I use because I always have it on me. The only disadvantage is I do find that I have to either dictate by speakerphone or by a landline because I'm trying to physically look at my phone to kind of figure out what I'm supposed to be dictating on there. Option number 3, surgeon's lounge sign. So this is what I initially wanted in the beginning when we were told we needed to dictate this way. So, you could hang the synoptic operative report in an easily visualized area where surgeons typically sit down and dictate their operative reports. And the advantage is, again, easily accessible if you hang it on every bulletin board, and low to minimal technology and intelligence. The disadvantages, you're kind of forced to dictate at work. I don't know about you guys, but I'm often running from hospital to hospital or trying to get home to see babies. So certainly I don't always dictate at work. And then secondly, this is Duke University's OR lounge. And I don't know about you, but ours does not have reclining leather chairs and massage chairs and things. So right now our lounge at Wesley Medical Center is being redone. So we're in a closet, and that is not an ideal place to dictate. So option number 4 is, putting this synoptic operative report in the EMR. And I think this is probably what most centers are going to do. So you can see on the right side of the screen, there are all the options for the synoptic operative reports. And then if you look down in the second part of that, where you can choose yes or no for each one of those and why. So you essentially just using EMR with dot phrases or an accessible operative report that you can get access to right after the surgery. The advantage is this is going to be more efficient for data collection, especially because you don't have to wait for the surgeon to dictate. You don't have to wait for the transcriptionist to complete it. You don't have to wait for the surgeon to re-sign it and then send it off. So that takes out quite a bit of time that can delay the data collection. And some of the templates for the most popular electronic medical records are provided by ACS, but not all of them. The disadvantages, certainly there's a moderate amount of technology intelligence. You have to be able to access this from wherever you're operating. There's of course going to be an adjustment period. None of us like to change what we already know how to do. And if you're like me, I operate at many different hospitals, 2 main hospitals that I do cancer care, but I might go to 5 different hospitals and outpatient surgery centers a day. And there's a different EMR at every hospital. So certainly adding on more, processes that we have to do can lead to burnout. And EMR is one of the highest reasons of burnout. And so when we kind of look at this, just real briefly at this infographic on burnout, that top or that bottom right, complicated electronic health medical records, that's one of the most common reasons for physicians to be burned out. And so certainly we don't want to add to that by giving you another thing to complete in the record. But the middle one over on the left side, excessive focus on data over patient care, I would say that that's really where I was when I first started hearing about synoptic operative reports. I thought that this was focusing too much on data, and it really, wasn't about patient care. But the more I learned from this, the more the main point is that these operative standards are based on techniques of cancer care surgery that prolong the overall survival of the patient. And if that's the key point, then that's good enough for me. And I would be happy to do anything that can help with the survival of my patients. So again, how to get surgeons on board, make it easy, make it accessible, give them multiple options. Not everybody's going to like the same option. And then certainly educate surgeons on the importance of these reports. If they're at a cancer accreditation center, they're going to have to be compliant anyway. And it also improves data collection so that we can monitor and improve the quality of patient care, which I think is the most important. So those are some of my resources there. And that's my little girl that I brought in 7 weeks ago. She's her name is August Grace, and she's, like I said before, very good sleeper, and I'm very blessed with good family. So that's all I have, and I would be happy to answer any questions that anyone has.
Yes, Lindsay, that was fantastic. Thank you so much for that presentation. Extremely clear and concise description of kind of the evolution of rectal cancer care. One question I had, and you kind of alluded to it already in your talk, but your criteria for watchful waiting with the TNT, you kind of mentioned proximity to sphincters, but do you have an algorithm that you use of the patients you may choose to put on watchful waiting?
Yeah, I don't think there really is, besides the key points of what it looks like and where, what the MRI and what the physical exam look like. It used to be that most of us would say, oh, well, I would offer that to someone who's 80, or I would offer that to someone who is going to lose their anus. But those would really be very, few and far between. At the American Society of Colorectal Surgeons meeting that we had 2 years ago, they really put that up for discussion. And would you offer a 40-year-old who, wasn't going to lose their sphincter, would you offer a 40-year-old this option? And everybody on the panel said yes. And so I do think that because we're watching them so closely, we're very likely to see recurrence before anything bad happens, and we're very likely to catch it in time to treat it. And so for now, I don't think that there's really a specific, distance from the sphincter that needs to be achieved anymore, because the data is so good.
Awesome. And then one follow-up of that, you mentioned MRI, and then also, probably flexible sigmoidoscopy or rigid sigmoidoscopy, however you're surveilling that. How frequently do you do that? And then for how long? What's that protocol?
That's really a great question, because I'm not sure we know how long. I'm doing every 3 months. I've seen anywhere in the research 2 to 4 months. I tend to try to alternate. Also, I do my own ultrasounds in my clinic, so I tend to do an ultrasound as well. Those are really hard to interpret after someone's had some amount of scarring, but if you follow them over time, you can see changes. And so I've been doing every 3 months, and then we're going at least 2 years out at this point, every 3 months. But then after that, usually for rectal cancer, we can kind of slow down on that. If they're going to have a local recurrence, according to our surgery data, they're going to have it within the first 2 years. So.
Great, thank you.
Mm-hmm.
I don't want to bogart all the question time, so anyone else hop in if you want to. More of a comment, I guess, on the synoptic operative reports. Is you point out the fact that, boy, it's really hard when patients go to multiple institutions. And then, for these webinars that we've been having for the Kansas chapter, we've invited all chapter members and not just those for Commission on Cancer accredited sites. So just for my purposes, these synoptic operative reports are really for Commission on Cancer accreditation. But like you pointed out, these point to the key principles of oncologic resection. So really, important and could be useful for all surgeons to use. So with that disclaimer, it's hard to get all surgeons on board. And then especially when you go to different facilities. And one thing that I didn't realize initially with this standard rollout is that at your facility, everyone has to do it basically the same way. And so what that means is that, some people who only want to dictate, they just wanted to have a pre-printed form. And you can do this. You can have like a PDF form where they mark it all off by hitting all those data points. It then gets scanned in to the EMR. But then everyone at that facility has to do that. If it's a dictated operative report or gets put in the EMR, that or those dot phrases, I think all count.
Yeah.
But that was one point that I didn't realize, is that at your facility, everyone has to agree with what approach you're going to take.
Yeah, I was not aware of that as either.
Yeah. And so we haven't had anyone request that, they just fill out some sheet, but I think maybe some facilities where they're, and you bring up a good point, when you're still dictating all of your operative reports, where I know a lot of places, maybe you're dictating directly into the EMR by whatever means, remembering to put it in there is the hard part.
Right.
And so I think that's going to be important for all sites, of trying to put as many visual reminders as you can in those key areas where physicians dictate would be good.
Yeah.
With our group, we kind of transitioned to dictating directly into our EMR. I know someone on the calls previously had mentioned that there is some hesitance on the surgeon's part, because the transcription does not move as quickly as our mouths. And sometimes, you're thinking these thoughts, and so you don't catch all your editorial things that it didn't quite transcribe correctly. And you read it back later and you're like, oh my gosh, this is completely wrong, sound ridiculous. So there is some editing things that I think are problematic with doing that. But if that's something that some facilities do, having kind of the power mics available for physicians, that was one thing that may help with physician adoption of dictating into the EMR, if that's something places are considered. So just another option if any places are kind of struggling with surgeon adoption of this.
Yeah. I know from my standpoint, I really needed peer pressure to get on board, because we were undergoing our rectal cancer accreditation. And, when you're faced with the number of, operative reports that you versus the only other two people who might be doing it, at that facility, you certainly, we're all perfectionists and grade A students. So we want to win. So that really helped me get on board.
Awesome. Yeah. And so what we ended up doing, we use Epic at our facility. And so there was some talk that Epic would potentially roll out a product that would have all this built into it. And I still don't think that has quite been finalized. But what we have found is our local IT people were able to very easily create these dot phrases for us. And for the different disease sites, I mean, it honestly takes maybe 15, 20 seconds.
Yeah.
And you're right, the fact that we know adhering to those standards improves care. And for us, we're kind of more of a community program. And certainly for our cancer tumor registrars, and then everyone helping them, that's not their only job. They have multiple jobs within the cancer center. And so when they told us, oh my gosh, this is so much easier, this takes so much less time, that was another kind of push for us of, okay, well, if it's helping our partners here within oncology, then we'll do it. And honestly, it's not been onerous to do.
Yeah.
I was curious, from some of the people on the call, Heather, Mary Beth, or Hope, is there a way that you've heard where those things can be automatically pulled from O2 into like the registrar's file if it's within a template? Like in theory, if you have a dot phrase, it should be able to automatically populate into like a red cap or a registry. rather than having to go and do it by hand. But I was just curious if that was a good theory, if anyone's actually heard about that in practice.
I have not, but it'd be a really good question of Tim Metcalf. He's usually on top of those type of questions, and it might be worth checking in with him.
I'll admit I don't know our CTRs. We've been trialing this now since early July, and I haven't gotten any feedback, nor have I asked if they're able to directly import that. So that's a great question.
I
Does
think
the American College of Surgeons have a process for that? Because sometimes they're all over that sort of automation questions, sometimes not.
Probably because it depends on the EMR system that you're using. I have not heard anything that I've heard from the college directly. The COC committee I'm on is not related directly to the operative standards. It's related to education. And there has not been conversation about that, but I suspect it's because if we use Epic and another uses different brands, we wouldn't be able to necessarily guarantee that at a national level. I wonder too, Jen, if you haven't heard much feedback, because the registrars don't keep up in real time. Obviously, how can they? And they need that follow-up information. So what we hear on breast is that they're usually functioning about 12 to 14 months behind. So you may not start hearing feedback, or I don't know if that's something you'd want to ask for feedback for early on. So you don't do this for a year before realizing it's not as ideal as you intended it to be.
Yeah, I think that's a great point. And the secondary point of that is that, starting January 1, all sites need to be hitting that 70% mark. And so you're right, if they're normally 12 to 14 months behind, we need a system with those disease sites to make sure that we're monitoring that much more closely throughout the year. So that you can catch any of those deficiencies early. And I will admit, we haven't thought of that process yet, but we need to, it seems. So more work to be done.
Yeah, just put that on the list. Yeah.
Because the registers are just getting more and more things layered on top of them, and hospitals are having a really hard time across the state maintaining enough people in those roles.
Yeah, that
we
may be
definitely
something.
Had trouble during COVID and in the last 2 years with maintaining staff, and it is just so hard to get that data in there. And so, yeah, getting this implemented in this time when we thought that such low staff is going to be a challenge.
Yeah, that's something as part of our, individual steering committees or our cancer committee meetings. It may be something to where we just need to put it on a monthly basis, that we review the prior month's cases and make sure that we're hitting the standards. I know that's what we ended up doing for the pathology standards, so 5.7 and 5.8. So the TME, completeness of resection, 5.7 and 5.8 is the lymph node sampling for pulmonary resections for curative intent. And in similar fashion, we ended up having to every month make sure that we looked at those numbers and that we were keeping a running tally to where we didn't get behind or have some deficiencies and not notice those in time to be able to recover from them. So add it to the to-do list. Any other questions? It's great discussion. Any other questions from the group?
I personally really hope that in the future we have some data that comes out, and I don't know how this would exactly look, but on what Lindsay was saying about if this does actually improve anything from the cancer outcome standpoint. And it will take a long time, of course, for that type of data to come out, but I think there's probably some early things that you will be able to potentially see, right? Like in terms of for breast or even for colorectal, like lymph nodes retrieved, number of lymph nodes retrieved, maybe things like that. If people are forced to have those check marks at the key steps, And that I think is ultimately what's really interesting, is if you can have some correlation with clinical, at least resection or clinical outcomes in some way, and that will really be where it's worth it, right? Because otherwise, if it's just paperwork and we can't ever prove or show that we're improving care, that's, that's frustrating.
And Dr. Larson, to your point, I would love to see that by race and ethnicity, because we're seeing such health disparities, and it'd be really interesting to see if there's differences in approaches or outcomes, et cetera. I think that we still haven't fully cracked that nut of what's causing the disparities, and any additional data would be useful. One of the things I chatted to Dr. McAllister for just quickly, and I heard watchful waiting. It reminded me how prostate cancer went from watchful waiting to active surveillance, because patients like to think that they're not just waiting for their cancer to show up, but they preferred that active word. And I know that's not your term, the watchful waiting. It came from others, but I wondered about think about terminology and what's the opportunity to shift something for patients.
That's a good point. Yeah, very, very important to keep that in mind for the patient's quality of life and their thought process, as they're not waiting around for something to come back, but really just surveilling them. Yeah, that's a good point.
Really good presentation.
Thank you.
Yeah, that was a fantastic and concise presentation of a very complex field. So, all right. And I think, again, so afterwards, I'd be hopeful that we could send this out to the entire Kansas chapter members to be able to kind of watch at their leisure, because I know trying to have schedules mesh is difficult to do, but I think it's a fantastic resource for all members. So again, Dr. Strader, thank you very much for your time and your expertise. This was fantastic.
Of course. Thanks for asking me.